And we are joined by Devin Green too. How do hospitals get paid?
Hi, thank you for having me. Devin Green, Vermont Association of Hospitals and Health Systems. And yes, here to answer the question of how hospitals get paid. I want to put a disclaimer right up front that I am, just like Jessa is not a doctor, I am not a finance person. So I'm going to do my best to translate things into English. But if you want more details, happy to bring more of an expert in here to discuss. So 3 major payers, I've split this up for hospitals between commercial insurance, Medicaid and Medicare. There are other payers, there's TRICARE, there's the VA, but they're a very small percentage. So we're not going to delve into that right now. For commercial insurance, as you heard from Jess's testimony or Vermont Medical Society's testimony, hospitals start out with one charge master. So they provide charges for everything. And then essentially the payers come in and tweak off of that in different ways. Commercial insurers negotiate hospital payments through contracts. They do this through fee for service, capitated payments, or episode and bundle payments. Again, I won't spend too much time on here because you're having Blue Cross Blue Shield up next. And I do want to make a huge connection. Medicare Advantage works like commercial insurance, not Medicaid Advantage. Oh, thank God we don't have Medicaid Advantage. So yes, there's an interesting interplay between traditional Medicare and Medicare Advantage that I'm happy to speak about further.
Since
We're so excited.
Somebody asked a question, I don't remember who it was. It might have been Leslie or Alan or, can you talk about charge master and how does a hospital even?
I
mean, somebody had asked the question around the $58 and change of that. And how does that correlate to what the charge is? And is there any correlation? And also the charge master is just a fictional kind of number that's sort of out there. Because it really depends more on the contract. So how do the charges even get set? Mm-hmm. Is there rhyme or reason to it?
That is a great question. And I do not know the answer to how charges get set. I wouldn't call them completely fiction, but I would say that, you start in one place and then there are a lot of tweaks involved. So I'm happy to have someone come in here and talk about setting the charge master. But I'm guessing different hospitals tweak it a little bit differently.
Oh, Leslie.
Sorry. I'm just thinking about reimbursements from these different entities. Can we say that for that fine needle aspiration example, that it would be the same in every hospital or not necessarily for Medicare?
Great question. I'm going to get into that in the Medicare piece.
Okay, thank you.
And the answer is, I thought so, but now I don't know.
Okay.
Yes. So before I move off of commercial insurance, I did want to harken back to the healthcare advocate talking a little bit about community rating versus age rating with some of the information he provided yesterday. As he noted, he was providing premiums for 40-year-olds. I just wanted to give this committee a sense of what premiums look like for 64-year-olds in other states.
Per month?
As per month. And so Vermont and New York both have community rating, and then Maine does not have community rating. And you can see that there's a significant increase for someone who's older. That is what I have for commercial at the moment. And now I'll be moving on to Medicaid, unless there are more questions about commercial.
Can you speak to, because, we have this whole section on reference-based pricing and it revolves around hospitals and setting, except for this section 5, which I'm frankly not sure what it pertains to.
You only hold up 2 and 3.
I know,
I'm section 5 within section 3, yes.
5 and 3.
Yeah.
But so, what this bill is contemplating is really doing a reference-based pricing for hospitals for commercial payers, which would really affect facility rates more so than what Jessa was talking about, which is provider. Can you talk a little bit about how hospitals get paid from commercial, which might be different than how they're paid from Medicare or Medicaid? I don't know if you're prepared to.
Yeah, I mean, I think a lot of that depends on the contract. I will say that Medicare sets a lot of the standard for payments. Typically, when Medicare changes, those changes can flow into the commercial sector also. And, commercial insurers can base a certain percentage either off of the charge master or even through Medicare. There's actually nothing stopping anyone from doing reference-based pricing right now. You don't need legislation to do it. It would be just a matter of the negotiation process. So it can happen in various ways through the contracting process.
Do commercial payers, typically doesn't Medicare pay kind of an episode?
Yes, and I will get into that.
Okay.
Yeah. Do you want me to jump right to Medicare?
Well, yeah, I'm just thinking, how do you set reference-based pricing if commercial payers don't pay that same way?
Yes. Okay, let me speed through Medicaid real quick, and then I'll get to the Medicare piece. Medicaid, what hospitals have been dealing with for a while, it's been the all-payer model prospective payments. This is where they set a rate that were derived historically from base payments and provided monthly fixed payments. Hospitals have been appreciative of that. That was very helpful through COVID. And it was a lot more beneficial than the way Medicare was doing the all-payer model, which was essentially fee-for-service. It was prospective payments, but shadow claims, sort of fee-for-service thing, and not this truly fixed prospective payments. So that is how Medicaid has been doing it for hospitals. There's also other funding in Medicaid, like the disproportionate share hospital payments. States get wildly different amounts for their DSH funding. I just wanted to point out here that Vermont has 23 million in DSH payments. New Hampshire has 213 million in DSH payments. A lot of that is based off of how the maximum cap of what states could get. There was a formula for it many decades ago. It was set for these DSH payments. New Hampshire had a very high cap. Our cap is 44 million, but we are still below that cap at 23 million. There's also graduate medical education payments to recognize that medical education is not efficient because you're teaching and there are various costs to that. And so those are applied. And then there's this thing called state directed payments, which Vermont largely does not do in the way that we see other states do, because it's done through Medicaid, like an MCO, partner, a managed care organization in Medicaid. And we don't have that system, so we don't do that.
Go ahead, Leslie.
I never understood DSH.
Yeah.
So I don't know if it's understandable, maybe.
Yeah.
So is it just a federal law or something, and then they just hand out money?
Yeah, it's federal funding.
Yeah.
It's a recognition of there are requirements around it, and there are requirements around the sort of populations that you're serving. It's typically for lower income populations, and there's a threshold there. You have to provide certain services like birthing services and inpatient services, I believe. But I can definitely write up a whole summary for you if you want. A lot of the details are escaping me at the moment.
I don't know how important it is as we go through this process, certainly don't need it to work, but I would want to know, how do we increase it?
Yes,
Is there any access to that?
if you put up state dollars, which I know
Also, it requires a match.
it's a match. Yeah,
Do you know the
I
percent?
think it's the typical FMAP. Yeah,
It's our FMAP.
yeah. Yes, I'm happy to give you more details. I think the dish piece I just wanted to put in here because as we make comparisons to other states, there are various pockets of funding that are different in different states. Okay, Medicare. All right, before I get into the busy slides, and we're gonna take a breath, we're gonna do this together, it's gonna be great.
We have our skis on.
And I'm gonna bring you back to my January presentation where I said, what is a hospital? And I talked about the different hospitals. And I've broken this Medicare funding piece out into two different types. Realizing that there are other variations that our state has, but I want to try to keep it simple to you. So I broke it out into the two main types, which are the critical access hospitals and the PPS hospitals. So with that, I'm going to jump into the Medicare piece. So Medicare and critical access hospitals, really the critical access hospital status was set up to ensure that there was access in rural communities. It's 8 hospitals in Vermont, and the main takeaway is that it is supposed to be sort of cost-based reimbursement, so allowable costs. And previously, it was at 101%, sort of acknowledging that these hospitals need a margin. But since then, there's been a 2% cut. So really, it's allowable cost of 99%. So you don't get that sort of operating margin piece that was intended initially. You have a little bit of a cut there. And then you don't get paid the deductible or the cost sharing that the Medicare patient has. In this piece, you sort of see the process for going through and directing the expenses, reclassifying the costs, adjusting them, assigning the gross patient charges to cost centers, and Medicare program charges. And then at the end, you have a settlement where you have the Medicare costs. You also have reimbursable bad debt. And then you also take out the coinsurance and deductibles and end up with your payment. So that is the critical access hospital piece. Unclear how reference-based pricing would impact critical access hospitals. I think that is worth delving into this process. And when I've heard folks talk about reference-based pricing, I think we've heard them either talk about it as applying to all services or applying to certain hospitals. And I think the certain hospitals piece is, keeping critical access hospitals out of it for the most part, if they don't want to participate, just because we're not quite sure how it will impact them. That being said, it's possible that reference-based pricing set a certain way will increase reimbursement to critical access hospitals because of a couple of them are definitely lower costs.
Mostly.
Well, what needs to be done to make it doable, like what you're saying? What has to happen?
More analysis, yeah, of the impact.
More now, so before the bill or in the
Yes.
bill?
I would say using the process from the bill. the Green Mountain Care Board taking a look at that
Is that rules?
and looking at the impact. It could be rules, it could be, there's a stakeholder group for the reference-based pricing, so it's meeting with that stakeholder group and understanding the impact.
The question is, how does that get analyzed? I just want to understand the question.
I think it's looking at the various proposals. There's no proposal on the table right now. And so once a proposal is made, hospitals can go back and analyze the impact, like what does this look like compared to now versus under reference-based pricing.
So you need the proposal first.
Yeah. The other type of hospital is PPS hospital. There are 5 of these hospitals in Vermont. One of them is the Academic Medical Center. They get certain adjustments. The other is Brattleboro Memorial Hospital is a Medicare dependent hospital. They get a certain adjustment if they meet certain criteria. But generally, how these hospitals are paid through Medicare is they're paid per discharge, not for individual items. And they're paid a base rate where there's a labor-related share that's adjusted by wage index of the area, so it can vary nationally, and a non-labor share that's adjusted by a cost of living adjustment factor. So that can also be different nationally.
Is it different statewide?
That is a great
Adjustment.
question. I don't know if it's different statewide or not. I can go back and look at that.
To interrupt.
It's possible. I know that, Chittenden has not always been considered rural, so it's possible that there's a rural factor versus a metropolitan factor, but I will go back and check on that and get you an answer. And then once you have that, each case is categorized into a diagnosis-related group, DRG. And that's basically Medicare saying, we think this is what it costs for a knee replacement. We have looked at many thousands of providers, and this is where we've landed in terms of what it should cost. And then the physicians are paid separately under the physician fee schedule. So over here on the other side of the slide, you'll see sort of how it works. I took this from Wikipedia, but it gives you a nice layout of just the various adjustments that are made and the weighted payments and where the disproportionate share payment is added, because there is a separate Medicare dish too, not to confuse us more. So that's another payment that's under Medicare. That's not the same as our Medicaid dish.
What a funny word, disproportionate. I don't get it. I'm stuck.
Because I believe it comes from you're serving a disproportionate amount of lower income people or people who need more services compared to nationally to other
That's
hospitals.
very helpful. Thank you.
So, we have the discussion around value-based payments, capitation versus fee for service. So when you're talking about DRG, and I'm going to make a really bad analogy. Let's say you're an automotive repair business. Everything is assigned like a labor. Okay, you need new brakes and rotors. It takes an hour. That's actually set by the way the parts manufacturers, which I didn't realize, but for a mechanic who can get that done in 45 minutes, he's gonna make more money than the one that it takes an hour and a half, because you can only bill that 1 hour. So the DRG, is there incentive? Is there incentive to discharge? To get under the rate of discharge?
So I would say, the DRG was put into place, I think in the eighties, as a cost saving measure for Medicare. So Medicare was saying, doing these, charge for every little thing is costing us too much money. We're gonna set the rate here through the DRG. It is, essentially like it's still fee for service based, right? It just doesn't break out the services. It sort of bundles the services. But I would say that Vermont has a real culture of not discharging people. We've really struggled, especially compared to other states, and we've had a bunch of like ethics, Cindy Bruzzese from the Vermont ethics come in and talk to people, because what hospitals typically do is they want to have the perfect discharge. They want to have someone discharged to a place where if they need 24-hour care, they will get 24-hour care. And in recent years, with issues with capacity, there's been a real ethical dilemma of like, we can no longer do that. In New York, they just discharge people with a pretty bare bones plan, and Vermont can no longer do quite the wraparound planning that we would hope to do. So I would say that many hospitals, and the pushback I get from this is like, well, I see this person in the grocery store, this is a person in my community. We need to do something. We can't just discharge them. So it may incentivize discharge. I don't necessarily see hospitals doing that.
Is there analysis done at each hospital?
Of the discharge rates?
30-day readmission.
Yeah, 30-day
Essentially,
readmission, yeah.
what the DRG is weighted based upon what the actual is.
That I don't know, because we've been on the DRG. I can ask that question.
Leslie?
I just want to say the importance of these policies in the 80s when DRGs were instituted, Rockingham Memorial Hospital closed, bam, because of the change in the whole payment model. So when we make these kinds of decisions, it will have really important impact.
Yep.
And we lived through that. And that was simply because of DRGs.
Mhm.
But, we keep going back to, is it a failed model or is it a failed funding?
We know that. We already know that.
So if we're doing reference-based pricing, are we building upon a failed funding model already?
Yes.
And should we be doing that?
Well, how do you change the funding model?
So commercial does commercial pay on a DRG or?
Yeah, no,
Sometimes, okay, so.
I mean, I think what this legislation does, is it is moving towards both, right? That's the confusing part. We have reference-based pricing. We also have global hospital budgets. And I think in having the Green Mountain Care Board and stakeholders wrestle with this in a way, that is not sort of a snap decision, even though I know we need to move quickly on the affordability piece, will help us potentially get to a hybrid sort of situation where maybe we are starting on reference-based pricing and then there's a global hospital budget. And that could be the happy medium. So.
Very quick. I wrote that. Boom. Leslie and I keep writing each other's heads on our notes.
So I had a hospital reach out to me. It was actually Southwestern Vermont Medical Center who was thinking, they've spent a long time trying to get to Medicare, trying to bring their commercial down to the Medicare rate and trying to get to that 100% of Medicare. And they're trying to understand why it's been easier for other hospitals. And they sent us this slide, or a couple of slides that I'm just going to go through. I asked Southwestern Vermont Medical Center to look at 2 of the reference-based pricing states and where their Medicare is. And I got this slide that said for inpatient revenue per Medicare case, so not just per capita per person in Vermont, but per case, the University of Vermont Medical Center and consequently just about every other hospital in Vermont has much less revenue per case.
Why are we comparing to Montana?
Because Montana has reference-based pricing.
And why is that?
This is just Medicare revenue.
This is Medicare. So what I'm trying to say is if we would love to be reference-based price off of Providence St. Patrick Hospital, 17,000. The reference-based pricing, it depends on what Medicare you're reference-based pricing off of, right? If you are reference-based pricing off of your current Medicare that you're receiving, it may look a lot different. And again, I don't totally know if that's the case because I just got this information and Southwestern Vermont Medical Center is working on analyzing it further. But it's all just to say that I have gone into reference-based pricing thinking Medicare is the same everywhere. There's no differences. And I think it's possible that there are differences, that we want to be careful what we're basing our pricing off of, especially when we're comparing to other states. And so this just goes through and shows the same for outpatient in Montana. And then we also looked at Oregon because they have reference-based pricing there. And 30 out of the 33 Oregon hospitals have higher Medicare reimbursement than UVMMC. And if you compare Oregon's University Hospital to UVMMC, it's much higher. And same for outpatient. So again, as I was saying, I think I know people want to move quickly on reference-based pricing, and I understand the need to move quickly on reference-based pricing. But I do think a quick process so we understand how it has worked in other states and the ramifications here, as this bill is laid out, makes a lot of sense.
So I'm confused by the other slides. I've got Daisy first and then I have Topper.
So just to repeat, you are in support of it as it's written in terms of implication of or implementation of this. Okay. And I imagine that the scenarios in these charts are probably vastly different numbers of patients or, I mean, there's no.
This is per case.
Excuse me?
This is per case.
Okay.
So it is per patient case. And I think there is Vermont has been doing healthcare reform with Medicare for a long time. And I think this is potential evidence of what Vermont's healthcare reform has achieved with Medicare. We have saved Medicare a lot of money. And I think this is one of the consequences of that work.
Is that, I mean, what are you trying to say with these slides? Because to me, the message I'm getting is we've been getting far, far less from Medicare than states which which are doing reference-based pricing are getting.
Yes.
And if we go to reference-based pricing, we're gonna make a lot more money from Medicare.
No, I'm saying we are gonna make a lot less money than these states. Like these states might be able to absorb the reference-based pricing because they're Medicare, they're keying off of a higher Medicare. We're keying off of a lower Medicare. And so we are less likely to absorb, like we are not going to be able to absorb that cut necessarily.
Can I? Yeah. Don't these slides basically prove that we're not getting from Medicare what we should be getting? And we instead are getting it from our commercial payers? And that's not good.
Yeah.
So we're not basing our commercial on what we're getting from Medicare. These slides highlight that we are way skewed in getting our money from our commercial payers, and we should be getting it from our Medicare.
Yes.
I mean, I look at that and I'm thinking, we need better billers in room. But why are we not maximizing what we're getting from Medicare? Why are we trying to get it all from our commercial payers? Reference-based pricing doesn't change that.
I don't know the cause of this. I will say that we have had both, the all-payer model in place, which included Medicare reform. And so we're not sure of the impact there. We know that the all-payer model saved Medicare, I think, hundreds of millions of dollars. So that could have an impact here. We also know that we have a cap with the Green Mountain Care Board on net patient service revenue, which includes Medicare. So we have been capping everyone, including Medicare, for many years also.
How often do we negotiate our rate with Medicare?
We don't negotiate a rate with Medicare.
They just tell us.
Yeah.
So how do they tell them kind of one thing and us another? How does that work?
That, I don't know. And that's what I'm trying to, we are trying to look into that more and why that might be.
You mean
We're
VOS?
just, VOS, Southwestern Medical Center, but.
This also speaks to all the slides we've seen where hospitals across this country seem to be able to provide close to 100% of their care based on Medicare's rate.
Right.
And we are abysmal. And so now we're getting it from commercial. Great, we've saved Medicare a ton of money.
They're going at
And the
business.
bad news is that we've gotten it all from commercial ratepayers.
From people.
From people,
Not commercial ratepayers.
commercial,
from us.
Vermonters
Yes.
who are not on Medicare. I'm sorry, Topper, do you want to go ahead?
I think my question is answered. I was just trying to figure out how reference-based pricing, how we're gonna make out at all.
I mean, I think as the healthcare advocate, as VMS said, I think we need to look at it. I think that there could be a way to do it that is both sustainable and lower cost. That may be totally naive, but I would like to think that if we sit down and look at it, we might be able to come up with something.
We already at that point with the lower Medicare? I'm trying to figure out what good it's gonna do.
It would lower, so what it would be doing is lowering commercial costs. So it would, because we wouldn't be lowering Medicare. We would be saying commercial costs are pegged to Medicare at a certain percentage. My worry is if we're pegging to a really low Medicare,
That's my point.
that could be a problem.
Yeah.
So pegged to something else?
And I'm gonna go with Wendy.
I'm just curious, like, was this a purposeful thing to reduce our Medicare costs in Vermont? Like, I just don't understand this. We have an aging population, which is covered mainly by Medicare, and yet we're asking the rest of the population to make up the difference here. Are we so bad? Like, if this is comparing Oregon, but what are the other states?
I don't know, I can check. I know that this came to me because the person at Southwestern Vermont Medical Center was listening to the expert from Cleveland who was testifying in the Green Mountain Care Board, and he was like, well, I just want to look up Cleveland for a moment. And that was also much, much higher. I think they were at 14,000 and Vermont is at its 11 or 8,000.
Because we FMAP everything. We try to claw as much money from federal that we possibly can, and this is like, we just gave it up? I don't understand.
I mean, it could be an unintended consequence, right? Like, I don't know what caused this. It could be, I'm not going to speak with authority as to what caused this. I will say that this is just the information that we've received.
Okay.
Daisy and then Leslie.
No.
And we're moving to Leslie.
So in this bill, it's pegged to Medicare. I'm not sure if has to be a given, or is there an opportunity to think about something else?
I think it's okay to peg it to Medicare. It's just coming up with the right percentage.
Yeah, that's
I'm not sure I know what
what my thinking was around is, okay, so Medicare is low, but we've heard from Mike or Owen about a little bit about that dance about, so it's just a reference, right? So you
Right.
can do it 250% of Medicare, or whatever. It's the reference point. And I hear you that your concern is that Medicare is low. I think we're all in talk about the comparative rate. But
I don't go 100% Medicare for us.
Well, I think that's really interesting. It's the first time I've ever heard 250% of Medicare. So we can do,
Yeah.
So that's interesting. I have another question.
Yeah, go ahead.
I'm not sure how to roll this out, like when you do this giant rollout and then you can't even predict what's going to happen kind of thing. So are there small pilot things that we could do to test it? And what might that look like?
I mean, I think that could be, and Blue Cross Blue Shield has spoke to this before, and I think VMS did too, but it could be looking at rolling it out with a certain service across everyone. It could be looking at rolling it out to,
Yeah, you mentioned.
maybe there's a hospital that wants to do it, looking at a hospital. There are a bunch of different ways you can roll it out.
remember when we did the walk through the bill, we were talking about total cost of care. I feel like there's some devil in the details there around.
Devil in the details, I think. I'm sorry.
And just, I mean, I just keep thinking about every slide that we've seen for years and years. And I mean, I think Mike comes in here every year and he shows us a slide where actually our Medicare spend per Medicare person is actually lower than the national average. And yet then we look at our commercial rate and our commercial rates are by far, we are number one. Yay, we're number one. And
Yeah, we are lowest.
it's just, it's not we've spent all this effort into saving Medicare.
Can I ask a clarification
Yes.
question? How much of that difference is due to the rate that Medicare is paying versus the acuity of the cases? Because we've been putting a lot of money into Blueprint and other stuff
Yeah.
to help make our older folks healthier. So it's not a bad thing that they're healthier.
Right.
The question that drives that is that rate lower because they're healthier? In which case, that's a good thing. Or is the rate lower because Medicare is paying lower? And I think it's the acuity. And I think it needs to be clear on that. That's acuity versus rates. If our rates lower than what they're paying, in Oregon, Or is it just that we have a healthier population? And I think that needs to be clarified in those slides.
Yes.
Yes, happy to, again, like, this
The other side
is,
is seating,
Yeah.
not the seating, but doesn't send the
Yeah.
what message is that telling us?
Yeah.
We don't actually know what message it's telling. Is there a big problem or not?
right, and that's what we want to delve into, and that, I mean, the main message is, we need to delve into that problem.
Yeah.
And that's why a proposal that's like do 200% of Medicare right now keeps us from diving into that problem.
Yes. I mean, this is not all based on the conversion factor.
Right.
I mean, there may be a tiny variance, but there certainly isn't that. This is, like you said, acuity or.
Low rates.
Population
And
characteristics
we'd
versus
be,
rate.
we'd be basing reference-based pricing on the Medicare rate.
Yes.
In which case, and not, that those slides may or may not be telling us the story of what secret. That's all I'm getting at.
And that's a good point, Nolan. And I also think there's, there is room for hospitals. This is one factor. This is not the explaining factor for the way our system is. I think, as I've said before, there's room for our hospitals to improve on their costs as well.
Okay. Oh,
Does Vermont being a real healthy state has to factor into this, doesn't it?
I think it could factor into this. I think it's probably likely that it factors. Again, I don't know all the factors. I'm just giving the data at this point. I don't want to muck up the waters. What Nolan said was perfect. I'm going to leave it at that. Shoot, that was on the record too.
Strong word.
Don't have it.
Did you say you were gonna mention something about, the Advantage plans?
I can talk about the Medicare. I don't know how much I can talk about the Medicare Advantage plans, but feel free to ask me a question about.
Well, I understand that there's gonna be some new money that's poured into the Advantage plans.
Oh. I didn't know that. Oh.
Or what was, I missed that. I just heard billion and then I. Medicare, it's what?
There's gonna be some new money federally that's gonna be poured into Advantage plans.
Yeah. Right. That's why we said boo. I'm sure we'll see a lot of that.
And I'm saying it's looking like.
I'm editorializing.
You don't have to answer that.
Okay.
Yeah,
I don't know about the new money.
Thank you, Devin. Any
Yeah.
questions for Devin?
So the big thing that you're concerned about is the plan in terms, go ahead.
I am supportive of sections 2 and 3 as written. And even some of I'm happy to write up, what we support from other suggestions that have come from people. We do support this statewide plan also.
Thank you.
Thanks.
Right, how hospitals get paid. Let's talk to who pays hospitals. Sarah.
Thank you. Sarah Teachout with Blue Cross and Blue Shield of Vermont, and I may not have done my homework assignment exactly correctly. So the document that I provided to the committee is sort of a run through of the whole bill with recommendations for different sections. I'll focus on sections 1 and 2 since that's what you asked, or 2 and 3. Sorry, 2 and 3. I guess I'll just address a few of the things that you've talked about already and then get into my section by section. So yes, hospitals have charge masters, and that sets the prices. They're for broad kind of business lines, I guess. So we pay inpatient charges, outpatient charges, and professional charges. Those are like the 3 major types of hospital charges. In recent experience, most hospitals change their rate based on what the Green Mountain Care Board approves across a service line. So maybe they get a 3% increase from the Green Mountain Care Board, and they may increase their professional charges by 1%, their inpatient charges by 2% and their outpatient charges by 3%. Something that would, on average, or weighted average, come out to the 3% overall. That's how they tend to do it, but other hospitals pick and choose individual codes to change. So that's a little bit of how that works. We pay, exactly like Devin said, 3 major ways: fee for service, which is usually a discount off the charge. So whatever the hospital has on their charge master, the insurer pays some negotiated discount rate, right? So that's fee for service typically. We do bundled payments. We do both DRGs occasionally, and we do other types of bundles, like for colonoscopies or something like that in an individual hospital. It's different across every hospital. Every hospital is completely unlike every other hospital. And then we also do capitated payments, certainly not a whole lot of that, but a little bit. And we have special payment agreements for like outliers and unusual circumstances and different kinds of cases. So there's, that's pretty high level on how we pay hospitals. I wasn't going to get into how we pay independent practices because most of this reference-based pricing is focused on hospitals. I would also say how we pay non-contracted hospitals, so hospitals outside of our network. We usually negotiate a single case agreement if the person's health plan covers out-of-network services. So that's what happens if the hospital or the provider is not in network with Blue Cross and Blue Shield of Vermont. Let's see. Yeah,
Can I interrupt you there?
sure.
Do you not pay, if a hospital is out of network for you, don't you just typically pay whatever that state's Blue Cross Blue Shield's contract is with that hospital?
So because Blue Cross and Blue Shield, the systems network is extremely broad, we don't come across hospital systems that are out of network very often, but it's possible, especially as there's more and more contract negotiation disputes going on across the country, that a hospital could be out of the Blue Cross network. It happens more with an individual provider that may work at a hospital who's out of network, or an independent practice that's out of network. So that was the sort of high level, very high level. I guess the other thing I should say is that Blue Cross and Blue Shield of Vermont has our own, we call it a community fee schedule, but it's essentially the professional fee schedule that we pay all the non-hospital providers off of. And ours is not based on Medicare. Some health insurers do have Medicare referenced fee schedules. Ours is not, but we do benchmark against Medicare and Vermont Medicaid, and then national averages. So we do a lot of benchmarking work to know how our prices compare to Medicare especially. So we know roughly, if you look at the number on our fee schedule, what it is as a percent of Medicare. So I was going to jump to what I wrote about the sections. So in general, we think that reference-based pricing may be a useful rate-setting tool for the Green Mountain Care Board. That's all it is. It's a rate-setting tool. And it would need to work within their hospital budget setting process. Overall, and then I'll get into specifics, we support less restrictive statutory language and allowing the Green Mountain Care Board to develop and implement reference-based pricing for certain hospitals or services with broad guardrails set by the Green Mountain Care Board. I think overall, we think some of this language is too restrictive or too cumbersome to make it really work once they start digging into the details. So a couple examples of things that I recommend. And the first is something that Mike Fisher talked about in his testimony. I say, consider reversing the language to reflect that the bill is setting hospital prices, not insurer payments. So it's that first sentence there that says reference-based prices that represent the amounts that health insurers in the state shall pay to hospitals. It should be reference-based prices that represent the prices that hospitals in the state shall charge. And I don't know if it's insurers or commercial payers or something, but in reverse is the way we need to be thinking about this. So then I do have some comments here about site neutral pricing. So Medicare is not a site neutral payer. So we're confusing this concept of site neutral, which I'm not quite sure how it's meant in this bill, with how Medicare pays. So we know that, for example, Medicare pays critical access hospitals at a higher rate than it pays other hospitals. It pays academic hospitals at a different rate than it pays PPO hospital, or I might be confusing the hospitals. But so it's not a site neutral payer. So assuming that reference-based pricing results in site neutral payments is very, it doesn't really work in the bill, is my recommendation. The other thing, I think that what reference-based pricing could do, depending on how it's implemented here, is rationalize pricing across hospitals, because that's the way this is doing it, just for hospitals. It may not do anything for the difference between prices in hospitals and outside of hospitals, which I think is what this is trying to discuss, but I'm not 100% sure. And then the other thing that I would note is that there's all this language in here about reference-based pricing, and then it says, it contradicts itself later. It says that it can be adjusted for all these other, and I should have brought the bill, but the site of care, the acuity, the region, like all this stuff that would all of a sudden make it not site neutral anymore. So that's a little bit strange. And then I think Jessa did talk about how Medicare payments are adjusted for acuity. They are adjusted for some regionalization. There's a lot that's already in Medicare payment rates. And so to redo that again in this bill doesn't make sense. So I'm happy to work with other stakeholders to try and make the language a little more rational and work with actually how Medicare pays. So then a next one, I'm going to jump down under E2A, it says recommends that the definition to be expanded to Medicare reimbursement rate. I think it all should say and methodologies. And so the big difference is these DRGs. So that's part of the value you're going to bring to our system, or these diagnostic related group pricing structure that Medicare does, especially for outpatient. So I think that would need to be included. Then the language further says that the board may opt to update the prices. There's all this language in there about updating the prices if everyone doesn't agree with what Medicare changes their rates to be. But it seems to be suggesting they're changing the prices and not the reference. So the reference would be 200%, 300%, whatever percent is decided. And so just some of this is pretty confusing, the way that it's talking about what actually happens in a reference-based pricing system. Then I think that in E3C, where we're talking about ensuring that the decrease in prices for hospitals result in lower premiums for consumers, I think this is too limited for every situation and does not allow for what the Green Mountain Care Board, quite frankly, recently has been trying to do, which is lower the payments to hospitals so that they can increase the payments to primary care providers. So this would say lower the payments for hospitals, reduce the premiums. That's it. That would be the only option for the Green Mountain Care Board. So I'm not sure if that's what the intention is here, because I hear a lot of talk about shifting payments to non-hospital providers. And then let's see. Oh, and 482, right? You know, you just passed H482 that would lower hospital prices so that a health insurer wouldn't go insolvent. Like that would be prohibited in this language as well. So contradictory legislative language. And then I talk about E5, which is the piece that's a little bit confusing. And I'll just be straight up. We oppose allowing another entity, Agency of Human Services, set insurer payment rates for non-hospital services. That just creates a system that is not going to work at all. And I can talk about it in a lot of detail, but our system's already bifurcated between DFR being in charge of our solvency and setting the rates for some of the the lines of business that we do, the DFR sets rates for Medicare supplement products, college, they're like college payment plans. There's a few, a handful of things, VHI. So there's a few things DFR sets rates for, and then other things that the Green Mountain Care Board sets rates for, not always looking up to ensure solvency and whether or not the whole system works together. So I guess I'm gonna, before I jump into you didn't ask about hospital budgets, so you want me to stop there?
Yeah, let's stop.
And I had a couple other
Hospital budgets.
Yeah, so I was just recalling when Devin was showing those Medicare payment rates, that when I had our data analyst in here, she showed you some information about case mix, which is exactly what Nolan brought up. So it's the severity of the patients in the hospital. And I don't know if those are case mix adjusted, which you have to do. You can't compare any Medicare payment rates unless they're case mix adjusted. I also would say that I'd really like to see Dartmouth Medical Center on that chart, because that would really tell you what's going on. I get it's a different state, but they're the closest to what's happening here.
Clarify what case mix adjustment.
So they look at the severity of the types of patients who come in the door of the hospital.
Many.
Right? And then there's an average case mix rate for the hospital. So some hospitals treat very, very, very sick patients, and their case
So
mix
it's looking
rate,
at all admissions.
everybody together,
Okay.
everyone together. And we do know two things about the Vermont healthcare system, that we are having more people get care in hospitals that shouldn't be in a hospital. So that would lower the case mix rate. And that at least I remember from the chart, UVMHN's case mix rate is very low compared to other academic medical centers. So that could be some of the reason. I'm not saying it's all of the reason, but some of the reason why those payments look low on that chart. I think I've covered all the big things that we've talked about. So overall, Blue Cross and Blue Shield of Vermont supports, working on reference-based pricing. There are some very positive aspects I think it could bring to the state of Vermont. What I mostly mean is that it could rationalize pricing. It's not going to solve all the problems. So just to be super clear, we don't think it's a panacea for what's going on with kind of the mismatch in our healthcare system.
Leslie, you know this. So when you look at a charge master, how many charges are on one? Is it thousands?
Thousands and thousands.
Thousands. So
It's a spreadsheet.
yeah, it's fine. So I'm just thinking reference-based pricing for thousands of, when you say rationalize, I'm just trying to understand how.
I was going to ask a question, and maybe this will answer it. When you were in here, I think it was on 482, you had talked about the outpatient drug prices. And I had asked the question, why don't you just negotiate a better rate in your contracts? And you were, so,
Great question.
but in your contract negotiations, you just sort of say, we'll pay a certain percentage of your charge master for this subset of codes, right? And reference-based pricing would change that for you.
It could, and I need to talk to the team more about how reference-based pricing is implemented down on a very particular level. But so yes, and we start with the current, what we're paying in 2024 to negotiate 2025. So it's not like we rethink and re-rationalize what we're doing. We're just building on an irrational system. So just to start there. And then say we know that all the charges at the hospital in aggregate are going to increase prices by 3%. Then the hospital tells us which kind of, and this is where I started with lines of service. Usually they'll say, we're going to increase all the inpatient, they could be really simple. All inpatient, all outpatient, all professional charges, 3% increase, right? Simple, but that's not really how it usually happens. They all adjust them a little bit. And so they are choosing to increase the drug prices, and then we're just applying a discount to those prices. And so that's where we get this kind of, again, another irrational thing where the drug acquisition price may have dropped, but we're still increasing the commercial charge by 3% because it's unrelated to the acquisition of, the actual cost of the drug or service.
That was right. It was 340B. It wasn't.
It was 340B. Yeah. Yeah, and I guess that brings up one more point. I am not sure if this bill contemplates what we do in the instance that there isn't a Medicare equivalent payment or charge. Price, I should use the word price, right? There are things that commercial payers cover and pay for that Medicare just doesn't cover. So, or things that it might make more sense to have a different reference. And I'm thinking drugs because we really reference off average sales price. So it might make more sense to reference off that than to reference off Medicare for drugs. So just, giving a little flexibility here for the Green Mountain Care Board to do what makes sense. I have no idea if what I just said is the right way to do drugs, but it might be a consideration.
I have a question about, when this bill was going through the Senate, did you testify on that?
I testified on the vision. There was a vision document. And then I don't think I can't remember. I don't want to say if I did or didn't testify on the very last version. It changed a lot. So.
Thank you.
Yeah.
Sarah.
Super helpful.
All right.
Thanks.
All right, Kate. We've got short time, but we'll try to get through this.
Okay.
And just because I know that you get paid completely differently than the rest of them. Doesn't everyone love this system of
Yes.
care that we have?
Forget everything you've heard.
All right. For the record, Mary Kate Molman, I'm Director of Vermont Public Policy with Bi-State Primary Care Association. We support fairly qualified health centers in the state, Planned Parenthood, and free and referral clinics. Thank you for having us here to talk about FQHC payments. As Chair mentioned, we are paid differently. So with the physician fee schedule you heard from Jessa and the charge master from the hospitals, that is not, that does not go into at least the Medicare and Medicaid side of our payments. So you've seen this slide before. I just wanted to remind, like, FQHCs, we are really a community-based health center that provides primary care in addition to a number of other services. And I want to call this out because when FQHCs were set up, they were seen as a place where people would go and a whole swath of their care would be provided, whether it's dental care, family planning, mental health services. That was part of the FQHC model from the very beginning, on top of the primary care. And so a number of these services you'll see in the next slide, some are not included under the encounter rate, but a lot of these services are, as well as support for the enabling services. So this, I think, is really where we get into the heart of it. So as I said, and you've got the first, and I'll get more into detail in subsequent slides, but the Medicare and Medicaid pay FQHCs a set rate per visit. This is a bundled encounter rate that should encompass all of the services you receive in that visit. And there are some exceptions, which I'll get to, but that's the main point of it. Commercial payers, they are, you heard Sarah mention they have a community rate schedule. We, for Blue Cross Blue Shield, received that community fee schedule, but commercials can also pay us an encounter rate. Another key part of our funding is our 330 grant. This is that after going through a very competitive bid to be recognized in FQHC and continuing to meet very intensive regulatory oversight and quality metrics, FQHCs qualify for this 330 funding. And this is really to help FQHCs operate as that FQHC, that sliding fee schedule that they are required to offer to people under 200% poverty level. Translation, transportation, financial assistance services, a number of all of these enabling services that really set us a little bit different from other primary care settings. And then you also heard the 340B savings is a key part of maintaining our operational and financial health, though even that's sliding. But thank you for 266. All right. So Medicaid, this was established in federal statute in 2000. So we've had the same financial scheme for a number of years now, decades. And it's really established two ways to pay the FQHCs. One is the prospective payment system, which is you have a set rate that was established in 2000, 2001. And then over the years, you adjust it by either having reviewing the scope of services you provide and the populations you serve and the amount of resources that go into that care. That can be an adjustment, or you get an annual Medicare economic index, which is an inflationary factor that gets adjusted every year. You can also do an alternative payment methodology. And this is a method, it really can be anything decided between the FQHC and the state Medicaid program. It just has to be equal to or greater than what they would receive as a PPS rate. So this could be, you could put this into a more value-based payment arrangement where it could be like a capitated or even a global budget. But there's a lot of flexibility there. We also have some services that are covered under fee for service, and I've listed these out here. Any questions on Medicaid? Okay, Medicare. Again, this is in the Affordable Care Act, they updated our Medicare rate and shifted it to this PPS encounter bundle rate. This is adjusted this is set by CMS at a national level, and then it is adjusted by yet another inflationary factor, the FQHC market basket adjustment factor. And it's also adjusted by that geographic adjustment factor. So looking at the cost of care, the cost of living in each of these geographic areas, we get adjusted from that baseline Medicare rate. I'll also say that this covers a more narrow range of services than we cover under the Medicaid, because typically Vermont Medicaid covers a broader swath of services. Commercial, like I said, we typically are in Vermont, we are paid with Blue Cross Blue Shield under the community fee schedule. MVP tends to pay FQHCs that encounter rate, but also in the Affordable Care Act was a requirement that commercial payers needed to pay the minimum in aggregate, the minimum of what FQHCs would receive with a Medicaid PPS rate or that encounter rate, or come to another arrangement. So that would be that alternative approach would be what we have with Blue Cross Blue Shield. So that's the high level. I went through that fast. And I know it's lunchtime. So I'm happy to answer questions.
Well, I was wondering if you can address the impact of reference-based pricing.
Oh, yes. So as it applies to the bill, We still have a lot of questions, and if we were to go forward with this, we would want to probably offer some language that would be specific and acknowledge sort of the unique position of FQHCs. We would want to make sure that any reference-based pricing was compliant with federal law for FQHC payments. And also there's a question of what is that, if we were to benchmark it to Medicare, what Medicare benchmark would we do? Would it be the Medicare PPS rate for FQHCs, or would it be the Medicare community fee schedules that we currently receive? So there's some questions that would need to be thought through, and that's why I haven't brought any language. I really want to make sure we get this right if we're going to go forward with it. The other thing, if this is something that would fall under, if the price setting would be falling more under the Green Mountain Care Board's purview, we would want to be really clear. FQHCs are already very highly regulated through HRSA, the Health Resource and Services Administration. We have to meet a lot of reporting requirements, quality metrics, et cetera. We would want to be really careful that we did not follow under yet another regulatory oversight with the Green Mountain Care Board, especially when that can come into, when those two regulatory requests can come into conflict with each other. It's like mom and dad are fighting, and who do you ask for? And so we really want to acknowledge that there's a lot of administrative and regulatory burden that's already placed on FQHCs, and we would want to be really careful about inviting more.
Any other questions? I have just one really briefly. Because a lot of this concept has to do with reference-based pricing, particularly in the hospital setting. So you work off of a community fee schedule with Blue Cross Blue Shield.
Yep.
21% of your pie is from commercial. I'm wondering if, you have seen the effect of, with ever increasing prices, fees being given to hospitals, whether or not you think that is having an effect upon your ability to actually receive, commercial increases as well, or if you think there's a correlation between what happens in the hospital based on what happens with you.
I don't think there is a direct correlation. I think it may be more indirect. And we do not get to negotiate the community fee schedule. It is, and FQHCs can only negotiate individually. We would run across antitrust law if we, as all 11 of our FQHCs, decided to come together and say, hey, we want to negotiate our commercial rates. We're not allowed to do that. So as individual organizations, we really have no leverage to impact what we're paid commercially. We are working on making sure we're billing everything that we can bill for and all of those fee for service levers, but that's it. Whether or not, and again, I'm not knowing what the data is, but we don't see the same increases that the hospitals see. And that I think could potentially put us at a disadvantage. It suppresses one of our funding sources that if we weren't spending so much money in the hospitals, and if we were investing our healthcare dollars where they could be really effective, which is in that primary and preventive healthcare space, then I think it would put FQHCs in a better place.
Right.
I understand it's lunch, so this may not be the time to get in depth.
Okay.
So I'll just put some questions out there that'll come back. We can come back to later with other witnesses too, that I keep as I'm processing everything. I'm just trying to find the language and write it down, but now that it's my turn, I'll just fumble through it. So I'm curious, how much, you may not know this today, but how much time is spent on billing for fee-for-service primary care versus, I can't think of the word for it right now, even though it's been mentioned today, the model where, you pay per life.
The
Thank you, capitated payments, yeah. I'm curious in general for not just federally qualified health centers, but for primary care providers who are independent practice and in the hospital system. So maybe we can look at that later, but I'm just curious how much time is spent on that and how much administrative burden could be relieved if there was some universal financing, whether that be through some pool of money from all the payers, or whether that be like a universal primary care system.
Yeah.
And I guess a question I would have for you, because we heard from VMS about this, what would be the pros and cons for the federal qualified health centers of having a publicly financed universal primary care system where they sent like the basic primary care services are just covered by capitated payments of some kind, which would then free up all that administrative burden of billing and stuff.
Yeah, so I'm hearing kind of your first question is the administrative burden of fee for service versus.
Yes, yeah.
I'm going to give an unsatisfactory answer by saying it depends. It depends on what data you want collected under the capitated system to measure how well and the quality of care that you're providing. So one of the things that the fee for service system does really well is it provides and produces a lot of data. When you talk about the all-payer data claims database system, it's been a while since I've had to work in that space, reaching into my health research background. It produces a lot of data on utilization and diagnostics and acuity. So in that sense, it's really great, but it's not necessarily the best for the quality of care. That said, the capitated gives you a lot more flexibility. It pays providers for services that they currently can't bill for, but you may lose some of that data. So you have to figure out how you're collecting that data in a different way. Are you doing it through these, what we sometimes call shadow claims? Or are you doing some more kind of data mining in the clinical electronic medical record? So you have to think about what data you need and where are you using it and how are you using it? And that can have an impact on your administrative burden. So yeah, like I said, it devil's in the details and it depends.
I think that's good enough for now.
Yeah.
Because I feel like you're reinforcing a point that we have been hearing across witnesses about the different variables in the equation. What about the question of what difference would it make to have a universal system versus, and if you can't answer that today, maybe you could talk to your network. And
yeah, it's kind of getting into the financing question. And I think fundamentally for FQHCs, it comes down, are we getting paid to provide the care that we provide? And do our members, do Vermonters have access to the care? For FQHCs, see people regardless of their insurance status, ability to pay, we have to see them. Whether that care is covered out of Medicaid reimbursement, Medicare reimbursement, commercial reimbursement, or free or uncompensated care in our 330 grant, we're paying for it. Now, more support through Medicaid, Medicare, and commercial payers means we have more resources to expand services and expand services through our 330 grant. When you have less money coming through Medicaid, Medicare, and commercial, that care provided then comes more out of our 330 grant, which then requires us makes it harder to maintain the services we have.
I hear that. I must say though, as a client of a federally qualified healthcare center, I just had to pay a debt collection agency $60. So they sent it to debt collection over $60. So I'm just saying it's not as simple as it gets forgiven. There's actually, that's a barrier for people. So not to be.
Thank you, everybody, for staying late into lunch. And thank you, Mary Kate.